The following podcast is part of a certified educational activity titled A New Era in GPP Treatment, Clinical Insights, Biomarkers, and Emerging Therapies. Access the entire activity and complete the post-test at peerview.com/BPN 860. Downloadable slides and practice aids are also available.
Hi, I'm Dr. Steve Feldman, Professor of Dermatology here at the Wake Forest University School of Medicine in beautiful Winston-Salem, North Carolina. And it's my pleasure to present this presentation, A New Era in GPP Treatment, Clinical Insights, Biomarkers, and Emerging Therapies. I'm very excited about this because, for one, GPP is a serious illness. It's one of those things we see in dermatology that's potentially life-threatening. And we have a clear understanding of it now. There's a breakthrough in our understanding of interleukin-36 as a key driver of generalized pustular psoriasis. Now that we know interleukin-36 is the underlying cause for a lot of these patients, therapies have been developed to directly target that interleukin-36 pathway. It's kind of like when insulin was discovered as a treatment for diabetes. I mean, you're getting to the heart of the problem. Now, this is such a rare disease, you could never actually do a controlled study, but they did. And I'm going to share with you efficacy data from that trial. This is just a beautiful example of precision medicine that we have today. In this presentation, our goals will be to enhance your knowledge of the presentation, the disease course and pathophysiology of GPP, to hone your skills in recognition and diagnosis, and equip you with the strategies for the latest treatments that we have for GPP management. All right, so let's talk about disease burden, the impact, and what's really so exciting, the pathophysiology of GPP. GPP is uncommon and exceedingly rare in children. There's some ethnic variation where it's more common in Asia. And the acute flares can be life-threatening. It says here 50% may require hospitalization. In my experience, it may even be higher than that. And it's one of the few things in dermatology that used to cause mortality. I think our drugs now are so much better that if patients get adequate treatment, we shouldn't have much of a mortality risk. The impact of GPP is big. Now, psoriasis has a big impact on people's lives. Some years ago, I published an article based on looking at the quality of life of our patients with psoriasis. And we showed that psoriasis was as bad or worse than other major medical conditions. But GPP is even worse than plaque-type psoriasis. When you look at the quality of life scores of people with GPP, it's similar to what you see in hidradenitis. It's really bad. And so across all the dimensions of quality of life, you see here that GPP is worse than psoriasis. There's also a high burden of comorbidities. We see comorbidities in our patients with psoriasis. With GPP, there's the additional problem of life-threatening issues like the high output cardiac failure. There is so much blood flow going to the skin when your skin is all red and inflamed as it is in generalized pustular psoriasis that you can die of heart failure. So we really want to get the disease under control. When we see patients with GPP, they look sick. They may be having shaking chills. They may have fever. In my experience, a lot of time, they have hypothermia because they're losing so much heat through their skin. Normally, we regulate our body temperature by how much blood flow we send to the skin surface. So we're able, if we're getting cold, we cut back how much blood flow the skin gets, therefore less heat is radiated to the environment. When your skin is all red because of inflammation, you've lost that control and the heat goes out. And our patients, when we walk in the room, we may see them having shaking chills, and hopefully our office staff has already given them a blanket or two to help keep them warm. What excites me about GPP is the genetics and our understanding of the interleukin-36 pathway. Our understanding of this was really brought about, I think, by the identification of families where people would have generalized pustular psoriasis, even from an early youth, in childhood. And they looked at the genetics of these folks, and they found that in these families there was genetic mutations in the interleukin 36 receptor antagonist, the blocker of the interleukin 36 pathway. So if you didn't have that, your interleukin 36 went wild. And interleukin 36 is closely related to interleukin 1, and it brings in the neutrophils, and you get these pustular diseases. Homozygous mutation. So if you have you've lost both copies of your interleukin 36 receptor antagonist, or a heterozygous loss of both genes with different mutations. Either way, you have the interleukin 36 receptor antagonist deficiency, and you can have generalized pustular psoriasis run in the family. It can be from early in life. And this was a fabulous clue to what was causing generalized pustular psoriasis for other people as well, not the non-familiar forms. And it's really interesting. These mutations have been seen in other conditions like palmoplantar pustulosis, acrodermatitis continua of Halley-Poe, and acute generalized exanthematous pustulosis. And I hope you don't make me say that again. I'm just going to call it AGIP from here out. All right. Let's talk briefly again about the pathophysiology of GP and why I think the interleukin 36 pathway is the key thing that we really want to address. So in pustular psoriasis, you've got activation of cells and uncontrolled interleukin 36 production, whereas in plaque psoriasis, you've got the sentinel cells making interleukin 23 that's binding to its receptor, activating TYK2 that turns on IL-17 and the T helper 17 cells. It's a different pathway. The IL-36 pathway involves IL-36, which, very similar to interleukin 1, binding to a receptor that consists of two subunits. One is the interleukin 36 receptor. The other is the interleukin 1 receptor-associated protein. There's 4 types of interleukin 36. There's 3 isoforms that activate that receptor. And then there's the 4th isoform, which blocks the receptor. And if you don't have that interleukin 36 receptor antagonist, then you get uncontrolled GPP. So typically, the alpha, beta, and gamma isomers of interleukin 36 would try to bind to the interleukin 36 receptor and would activate it, but the presence of interleukin 36 receptor antagonists would limit the activity of those interleukin 36 alpha, beta, and gammas. If you don't have the interleukin 36 receptor antagonist, then you have the uncontrolled disease. GPP presents in many ways, and usually it's not to a dermatologist. Usually it's to the emergency room doctor or to a family physician. It can start off with a trigger. The triggers can be infection, a change in medication, maybe seasonal. People will say stress increases it, but I tell you, I think everybody's under stress all the time. So whatever stress they were under when their GPP flares up, they may ascribe the flare-up to the stress. One of the key things that people talk about as causing GPP flares is the use of systemic steroids. And it may be a trigger, but I'm not so sure, because I think what may happen in a lot of patients is their psoriasis is getting worse and worse, and they're getting inflamed, and the pustules are starting, and the disease is getting out of control, and they're given a systemic steroid because they're headed towards a pustular flare. And when the systemic steroids don't prevent the pustular flare from going all the way, the dermatologist may look at the patient and go, oh, it was the systemic steroids that caused the flare. A lot of people are getting systemic steroids. A lot of people with psoriasis, they may have poison ivy and get a a steroid taper. And typically, they don't have a pustular flare. Patients with psoriatic arthritis, the rheumatologists are giving them long-term steroids. They're giving them acute short-term steroids for for a hot joint, and the psoriasis doesn't flare up. One of my partners was involved many years ago with the primate colony here at Wake Forest. And there was a monkey in the Western diet, Western stress environment that developed psoriasis. And to make it worse, they gave the monkey some steroids and withdrew the steroids, thinking, oh, this will cause the psoriasis to get much worse. And the monkey's psoriasis went away and never came back. So it's possible steroid withdrawal is associated with GP, whether it's causing it or not, I don't know. Typically, I'm not prescribing a lot of steroids to my patients with psoriasis, although I did have a patient who came to me with a hot swollen joint, and I called the rheumatologist and said, can you see the patient? They said, no, I can't see him, but just give him a steroid taper. So I gave the patient a steroid taper, their joint got better, and there was no pustular flare. The diagnosis of GPP involves a history. You want to know if there's a history of psoriasis or not. You're evaluating their symptoms, especially fevers, chills, pain. Biopsy may be valuable, especially to help rule out infectious causes. I'm not doing genetic screening, but boy, if it were relatively easy to do, especially if there was any kind of familial history or early onset of pustular psoriasis, of a generalized pustular psoriasis, it would be nice to know what the patient's interleukin-36 receptor antagonist genes were like. A laboratory evaluation probably includes CBCs, complete metabolic profile. And then I think it's important to get a chest x-ray to look to see if there's an infection in the chest that's causing the flare. And I think a urinalysis and urine culture, because I think a lot of times the GPP flare is driven by infection, and often it'll be either in the lungs or in the urine. I think mostly in the urine. I think those are real common. As we mentioned earlier, GPP is more common in Asia, and there's an Asia Pacific diagnostic algorithm. So if you suspect GPP, you should suspect it when you see a lot of widespread erythema with pustules, especially if those pustules all look very similar. You're going to get the family history, do the laboratory evaluations. Then you have to exclude other things that may cause pustules. And AGEP is on this list. That would be a drug-induced acute pustular eruption, which may just be a drug-induced form of GPP. Wilkinson disease is a subcorneal pustular dermatosis. I wonder if it's just another name for GPP. I'm not sure I could distinguish the two. IgA pemphigus could cause a pustular eruption. I don't think it would have the uniform, even pustules that you typically see in GPP. There wouldn't be a history of psoriasis either, typically. Erythrodermic psoriasis is very similar, except that there aren't pustules there. And it may help to rule out infection, although there are very few infections that would cause a generalized pustular eruption. I guess, a generalized herpetic eruption might be in the differential. They recommend genetic testing if it's available. If not, a biopsy. And then the final diagnosis is going to be made based on putting all this information together. Now, GPP can be differentiated from plaque psoriasis. And plaque psoriasis, we now know, is an interleukin-23 pathway disease. It's that interleukin-23 TYK2 IL-17 axis that's driving the psoriasis. And we know this because why? Well, we know interleukin-23 blocking drugs make psoriasis better, TYK2 blocking drugs make psoriasis better, and IL-17 blocking drugs make psoriasis better. So we know those cytokines are all, and signaling molecules are all key factors in this pathway. But in addition, we understand the genetics of psoriasis. Now, there's over 100 genes that are associated with psoriasis, but each of the genes for each of the subunits of interleukin-23, the gene for the interleukin-23 receptor, and the gene for TYK2 are all genetically linked to plaque-type psoriasis. So we know those that plaque type psoriasis involves this interleukin-23 TYK2 IL-17 axis. The generalized pustular psoriasis is more of an innate immune inflammation with lots of neutrophils predominate. You get some neutrophils in plaque type psoriasis, but in pustular psoriasis, it's heavily neutrophilic inflammation, and it's driven by the interleukin-36 pathway, and there are mutations in that interleukin-36 receptor antagonist. Differentiating GPP from other pustular phenotypes of psoriasis can be done using some of the information on this slide. The generalized pustular psoriasis is typically sudden. It's got pustules that are all in a similar state of evolution, some of which may be coalescing into lakes of pus. And it's visible pustules, whereas in plaque psoriasis, the pustules are there, but they're so small, they're microscopic. We don't see the pustules unless we do a biopsy. There's an annual form of pustular psoriasis that I think is quite rare. I've never seen a case. I see a lot more palmoplantar pustular psoriasis than I do GPP. And it may be related genetically. These would be pustules on the palms and soles. Possibly there could be some plaques there. If there's plaques there, I would call it palmoplantar pustular psoriasis. If there's no plaques at all, I might call it palmoplantar pustulosis. Acrodermatitis continua have halopo is it's a debilitating, highly inflamed involvement of the distal fingertips, distal fingers, and with pustules and psoriasiform changes there. I kind of am a lumper. I think that's all fits within the spectrum between these plaque type psoriasis at one end to a GPP-like pustular psoriasis at the other end. And I think acrodermatitis continua of halopo falls on that spectrum. And then there's a pustular psoriasis of pregnancy, impetigo herpetiformis. Of course, the patient's going to be pregnant then and have the pustules on an erythematous patches. The relationship to drug administration may explain some of the difference between these, especially for AGEP. AGEP looks a lot like generalized pustular psoriasis, but it comes up suddenly in association with a drug, and there may also be eosinophilia associated with it. So this would be what looks like a GPP-like drug reaction. And it may be GPP just due to a drug. You can have dermatitis with secondary infection, and that secondary infection causing pustules. So if you see more of a eczematous process, a picture of atopic dermatitis with secondary staph infection, usually there's going to be more honey-colored crusting and not the typical pustules that you see in GPP. I think an acneiform process, especially maybe a fungal folliculitis, might present with some pustules. Subcorneal pustular dermatosis may be in the GPP family. I don't know if we need to distinguish that from GPP. IgA pemphigus is going to look different on a biopsy, especially if you get the immunofluorescence showing the presence of IgA. And then tinea can cause a fungal rash, like on the legs. You might get a Miyake's type tinea that will cause some pustules, but typically it's not going to be a total body inflammatory process. I want to talk about AGEP one more time. There was a very recent study that looked at gene expression in biopsies of AGEP and compared them to biopsies of GPP, and they found basically the same gene expression pattern. And so I think it's very strong evidence that GPP is that AGEP is basically a drug-induced form of GPP. So GPP is a rare condition. It's rapidly progressive and it has an enormous impact on patients' lives. We see the erythema and the pustules, and it's pretty characteristic in how it looks. These patients also, when you walk into the room, you can suspect GPP because the patient will be sitting there shaking with chills, and usually they're in an exam gown that your staff has gotten them in, and they're covered with blankets too. But despite that, they're shaking chills, and their face may be red. You'll see the pustules and the desquamation of the affected areas as the pustules resolve. We want these patients to be diagnosed early in getting them seen in the emergency room and getting them to a dermatologist quickly for appropriate treatment, getting them hospitalized if necessary quickly to avoid death, because this is one of the few things in dermatology that can kill you. All right, I want to switch gears now and talk about the strategies for taking care of patients with GPP. The disease severity is going to be bad, and so they're going to need a supportive care right from the beginning. They're going to need to be, because the disease can flare back up, they're going to need to be on some kind of maintenance regimen that maintains control of their psoriasis or their GPP so that they're not having GPP flares. You want to get the disease under control quickly and keep it under control. There's a variety of treatment strategies. Let's talk about these things. Topical treatments for psoriasis include this long list, including tar and salicylic acid, calcineurin inhibitors, trazodone. These are things we would not use in a patient with GPP because one of the things about GPP is the skin's already very inflamed, and we don't want to use topical treatments that are associated with more inflammation. A corticosteroid ointment will reduce inflammation, but tar can be irritating, as can salicylic acid and calcineurin inhibitors, and certainly topical retinoids and anthralin. So we're going to start with a topical steroid, probably. Even the vitamin D analogs can be irritating. They may have a role after the flare is under control to maintain control of maybe the underlying psoriasis, but when the patient is in the acute flare stage, probably the only topical we'll be giving them is a medium strength topical steroid in a non-irritating ointment vehicle. There are oral treatments. Cyclosporin is a typical one that might be used because it works fast. Methotrexate's good for long-term control of psoriasis, but you don't typically start patients on a really high dose of methotrexate because you could kill them with it. Whereas cyclosporin, you could start with a full 5 milligram per kilogram dose right away and get the inflammation controlled quickly. Now, cyclosporin at those high doses, will destroy your kidneys. So you don't want to keep them on that kind of dose. So typically, the paradigm for treatment of generalized pustular psoriasis or other forms of really acute erythrodermic psoriasis would be a sequential approach where you get them under rapid relief with cyclosporin, and then you give them something a little milder, a little less risky for the long-term management, like a oral retinoid like acitretin. Acitretin also is great for GPP in the acute phase because it can dry up pustules. It's something I commonly use. One of my most common uses for acitretin would be for the palmoplantar pustular psoriasis, where it would dry up the pustules, make the thick scale fall off, make the skin more amenable to the topicals, which otherwise might not penetrate. Antibiotics play a key role in the management of GPP because GPP is often caused by an underlying infection that's causing the flare. So typically, we'll probably, if we're hospitalizing the patient, we might start them on antibiotics right away, especially since we can't be sure that there isn't infection. If we're going to be giving cyclosporin or other immunosuppressive drugs, we're going to want them on some kind of antibiotic coverage that would cover them for a urinary tract or a upper respiratory tract or lower respiratory tract infection. It says here, use systemic steroids with extreme caution. I typically do not use systemic steroids. I'm a typical academic. In academic practice, we're not prescribing systemic steroids for psoriasis typically. And when we've seen a patient who had a systemic steroid, they almost certainly had a pustular flare. or some kind of erythrodermic flare. So it's like every time we see somebody who's gotten systemic steroids, they've had a pustular flare. It makes us think it happens all the time. Well, every time somebody outside of academics gives somebody systemic steroids, which is really common, and they don't have a pustular flare, they don't send us the patients. We only see the ones who have the pustular flare. So we get this warped impression. But given that warped impression, I'm not giving much systemic steroids. And then there's the biologic treatments. And I think they've been revolutionary in the management of psoriasis. As we'll see, there's some data on the use of psoriasis biologics for generalized pustular psoriasis. But now we have the potential blocking interleukin-36 pathway specifically. I think the biologics have been very helpful in reducing GPP flares by getting psoriasis under good control. In countries like Japan and Tunisia, where the IL-36 receptor antagonist gene mutations are more common, they may see, that kind of GPP flare. Here in the United States, most of the, if not all, the GPP I've seen has been patients with underlying psoriasis who've had a GPP flare of their psoriasis. And now that I'm able to keep, I've been taking care of psoriasis patients for 30 years. Back in the old days, I didn't have great drugs that kept the psoriasis under control. And so I would see patients who would have GPP flares of their psoriasis. Now that I'm able to control their psoriasis really well with IL-17 and IL-23 blockers, I think GPP has become more rare than even it used to be. Now, if you want to make a treatment for GPP and have it be approved for GPP, you got to do a trial, at least in the United States. In other countries, maybe they've approved some drugs based on case reports because the disease is so rare, they thought you could never do a study. To do a study would be very difficult for a rare disease like this. Cyclosporin is approved for psoriasis, not specifically for GPP. It works fast. It's a great bridge treatment to get people under control before you get them on something a little milder for their long-term control. Here it says you can start with a low dose and work up to 5 milligrams per kilogram per day. And that may be how you would use it in somebody who has a milder form of moderate to severe psoriasis that's not acutely ill. But if they're acutely ill and dying of their psoriasis, you want to get the disease under control, I'd probably start with the 5 milligram per kilogram per day and then reduce the dose or get the patient off it once you've got them on other longer-term safer treatments. Many biologics have been used for GPP, again, in small studies typically. And what you see is the interleukin 17 inhibition helps control GPP. IL-23 inhibition can help control GPP, especially in those people who don't have that interleukin-36 receptor antagonist deficiency. The studies were small, based on case series of patients, but it seems to work for many patients, and it's still a reasonable treatment. But now that we know GPP is caused by this interleukin-36 pathway, there are now interleukin-36 specific drugs, pathway drugs, that are either approved or in development to take care of this GPP phenomenon. Now, this is really a fascinating thing. They proposed to do a study, to develop an interleukin-36 receptor antagonist, and to do a study that would assess the disease. And the idea would be, well, you would just take a bunch of patients with GPP and you would randomize them to either the interleukin-36 antagonist replacement or to placebo. And you would follow them over time and see if they get better. How on earth could you do such a study? It seems impossible. First of all, you're dealing with this extraordinarily rare disease. Where are you going to find enough patients to do a study like this? And if you could find enough patients, who on earth with this life-threatening disease would be willing to go on placebo, and not be treated? You'd almost have to treat them with standard of care therapy along with the placebo. And patients who are hospitalized and you put the triamcinolone on them and you give them cyclosporin, they do clear up. How would you be able to tell the difference between a new drug and the placebo? It'd be impossible. And even if you could do that, you wouldn't be able to leave them on the placebo long enough to see a difference. And gosh, the sample size, you wouldn't be able to find enough patients to see statistically significant differences between the two groups. It'd be impossible. Well, it wasn't impossible. They actually did it. This is just the second most amazing thing about what we understand about GPP now. First is that we understand that GPP is driven by this IL-36 specific pathway, and that we can develop drugs that target that specific pathway. And then the second coolest thing is they actually did the clinical trial. This slide shows the trial that was done. They enrolled 53 patients. Now, to get 53 patients, I think they had more than 53 study sites trying to enroll patients. And there were a few study sites where they identified families. They had multiple people from individual families, and that helped with the recruitment. They randomized the patients 2-to-1 spesolimab to placebo. That helps you recruit the patients because you could tell them you got a 2 out of 3 chance you're going to get active treatment. And the placebo, the primary endpoint, is only 1 week. So you could tell patients you only have to put up with the placebo treatment for just 1 week. After a week, we're going to give everybody active drug. And we'll score the patients then. And then we'll follow the patients at week 12. And we'll see if we can take these people who are having flares of the disease and get them under control. This was a miracle, I think, that this study was done. But it's only got 53 patients. Can you really tell a difference between the drug and the placebo with 53 patients in a reliable way? Well, we'll look at the data in a moment. Here's the population of patients that were enrolled: 53 patients, 35 on the drug spesolimab, and 18 on placebo. Now, what is spesolimab? Spesolimab is an antibody, and it's an antibody against the interleukin-36 receptor. So basically, you've created a new form of interleukin-36 receptor antagonist that will bind to the receptor, block interleukin-36 from activating the receptor. So this is like insulin for diabetes, I think. It's targeting the specific thing that's missing and replacing it. And so in theory, it could work really well. In a clinical trial, you need specific measures for the disease. And so in this trial, they used the GPP PGA. That's the GPP PGA, the Generalized Pustular Psoriasis Physician Global Assessment. And it measures the global severity of disease on a 0 to 4 scale, where 0 is clear. Then you've got 1 almost clear, 2 mild, 3 moderate, 4 severe. And then you also have the GPP PGA pustulation subscore. So looking specifically at the severity of the pustules. You have the GPP PASI. That's the Generalized Pustular Psoriasis Area and Severity Index. You've got a pain score, and they include a measure of quality of life, the Dermatology Life Quality Index, the DLQI. They measured fatigue and symptoms. I want you to notice the average DLQI score was 19. Higher scores are worse disease. If you look at psoriasis studies, the DLQI score is typically around 12 for moderate to severe psoriasis. That's bad. That's worse than major medical conditions bad. And yet GPP is 19. That's hidradenitis suppurativa bad. This is having an enormous impact on patients' lives. In clinical practice, I'm going to talk about what percentage of body surface area is affected. It could be close to 100%. I'm going to talk about the presence of pustules. I'm going to talk about, it gave maybe an IGA score, a global assessment score of just, is this clear, almost clear, mild, moderate, or severe? Basically, for somebody who's having acute flare, it's going to be severe. I'm not going to use any standardized tools, but we'll talk more about those when we talk about clinical trials for assessing new drug developments in GPP. Okay, here's what happens. You give the patient spesolimab, and at the primary outcome, just 1 week into treatment, Half the patients with spesolimab have a postulation subscore of 0. All the pustules are gone in most of the patients treated with spesolimab, and in the placebo group, very few people get there. And then if you look at the global assessment of disease severity, 40% achieve success, meaning they've gone from moderate to severe disease down to clear, almost clear of their disease in just 1 week. This difference from the placebo is so enormous that even though the study size is very small, you see statistically significant differences. You'll see studies nowadays, where they're taking claims data on tens of millions of patients, and they'll show you that this comorbidity of psoriasis is more common in people with psoriasis than it is in the general population, and it's highly statistically significant. But the differences are minuscule and they're clinically meaningless, because when you have studies with so many people, you can find statistically significant differences because you have enormous power for detecting tiny differences to be statistically significant. When you've got 35 patients in one group and 18 patients in the other group, and you get a p-value of 0.001, the difference is clinically meaningful. You have to have an enormous difference in magnitude to see a highly statistically significant difference in such a small patient population. Here's what happens over time. You see rapid improvement in the GPP pustule scores and the percentage of people achieving success of no pustules or clear, almost clear their disease, and it's maintained out through week 12. You see even the placebo group, once they get on drug, they improve as well. And here's just some example patients. One who had the receptor antagonist deficiency, one who did not genetically have the receptor antagonist deficiency, but still had generalized pustular psoriasis through other pathways. And the drug worked well either way, because if you're blocking that because interleukin 36 is a key factor driving the neutrophils into the skin. I think this patient is these patients are really nice examples. You see the rapidity of the improvement, the clearing of the pustules, the clearing of the redness and the inflammation. The other thing I love about individual example slides like this is how they impact human thinking. If you believe in evolution, you would know that man did not evolve to manage data, like numbers like 1 in 100 or 1 in 1,000 or things like that. We learn things through stories. And if you want to convince a patient about the use of a medication, whether it's spesolimab or any other drug, you can give them all of the data on the drug, but it's not going to be very convincing because the human mind doesn't handle data very well. Better is to tell them, your skin disease reminds me so much else of this other patient I had, or this patient I saw in a spesolimab research study. The skin looks so similar. My other patient, or the patient in the study, did great on spesolimab. I think that's the right drug for you. That one anecdote can be more convincing than all of the data you present to the patient. Here's some more data, though. The pain improved not shockingly, when the pustules are disappearing, the inflammation's going away. Yeah, the patient's pain got better. And their quality of life improved, not shockingly. So the drug's effective. What about adverse events? They didn't see much. And there didn't seem to be much difference between the spesolimab and placebo groups. The one thing that maybe stood out was that there was a urinary tract infection with spesolimab. I think the infections may have been not caused by the spesolimab or not caused by a reduction in the immune system, but may be that having the urinary tract infection is what caused the pustular flare in the first place. So when you look at studies of GPP and you see infectious events, you could wonder, is the drug causing it, or was the infection causing the pustular flare? Spesolimab, which replaces the interleukin 36 receptor antagonist with an antibody against the receptor, works for controlling the flares, but GPP patients come back and they're flaring again, and you need to keep their disease under control. Can spesolimab be used to prevent flares? Well, it'd be nice to study it, but can you study that? I mean, it was heroic that they managed to find 53 patients who were having a pustular flare who would be willing to be in a study, a placebo-controlled clinical trial. Imagine how much harder it would be to try to do a maintenance study, because now you have to enroll people who aren't in a flare and hope that there'll be enough flares in the study to be able to detect a difference in preventing flares with spesolimab. And miraculously, they were able to do that study as well. Now, we don't have any head-to-head studies of spesolimab versus other treatments, but we can look at the evidence that's available. And as you can see here, at week 2, the spesolimab is even more effective than the IL-17 blockers are. So patients who were screened, they had a history of having pustular flares of GPP in the past, but they're not having one now. And they're randomized to be on placebo or spesolimab. And they're going to look to see if spesolimab could prevent flares from happening. And they're followed over time. You got to hope that it's kind of like the studies that were done of the COVID vaccine. You're vaccinating people or giving them placebo, and then you have to wait and follow them over time and watch to see whether they develop an infection or whether they die of the disease or not. And, you'd have to follow a lot of people over time. Well, sure enough, they did. And sure enough, the vaccine prevented symptomatic COVID. Now, I don't know if it prevented asymptomatic COVID, but it certainly reduced the symptomatic. And basically, once patients got that vaccine, you didn't see any more cases of symptomatic COVID. The vaccine was extraordinarily effective. Here in this study, the sample size in these groups is going to be tiny, but sure enough, they could detect the difference because the people in the placebo group had enough flares that half of them over the course of a year had a flare. And in the spesolimab group, boy, after the drug had a time to get into the system, after 4 weeks, the high dose, there were no more flares. And because that difference is so big, it didn't take a big study size to see these improvements. So 30 in a group, and yet you could still see highly significant, statistically significant differences between the groups, because when you give spesolimab, you stop the flares from happening. You'll notice there were flares in the first 4 weeks, and you could wonder, well, did the drug not have time to get into the system? I just wonder if the patients, there were some patients who basically were in a really mild flare, but they wanted to enroll them anyway because it was so hard to find people. And that's why you may have seen some flares in just the first, week or two. But after that, with the spesolimab high dose, the flares stop. Here's the patients with greater than or equal to 1 flare. And you see in the spesolimab group, it's low. But again, and those 3 that had those flares were just in the very initial period. After that, you didn't see flares, where in the placebo group, roughly half the patients, had flares. So spesolimab eliminates the flares, prevents flares in the maintenance period. And this is not shocking because now we know what GPP is. It's an IL-36 driven disease. It can be due to deficiency in the interleukin-36 receptor antagonist. And if you replace it, man, you've controlled the disease. How about side effects? Side effect profile, again, doesn't look very different from the placebo group. They did see a couple urinary tract infections. I don't know if the being on spesolimab predisposes somebody to having a urinary tract infection. I think it's more likely the urinary tract infections are what caused the GPP. But, I'd be prepared to be on the lookout for a urinary tract infection in these patients. And we should be anyway, because GPP flares may be caused by urinary tract infections. We should be looking for that in everybody with GPP. Spesolimab is approved for the management of flares and maintenance of GPP, but there's other drugs in development. Imsidolimab is another antibody designed to block the interleukin-36 receptor antagonist, and it was tested in an early study, and the patients did show improvement very quickly with the treatment in an open-label trial. Here's an example patient who did phenomenally well with improvement in their disease. Their patient's quality of life scores improved, and the safety looked pretty good. There were patients, one who had sepsis, but the patient had received other therapy as well. Again, I don't know if the blocking the interleukin-36 predisposes somebody to sepsis, or if it was their underlying infection and that was just getting worse that contributed to the disease. The sample size of these studies are so small, and because the drug is so effective, it's great that we can detect statistically significant differences based on these small sample sizes. But it is very limiting for our understanding of the safety of the drug. I think a lot of times when we're looking at, say, treatments for moderate to severe psoriasis, and they're enrolling hundreds of patients in the studies, they're not enrolling those hundreds of patients because you need that many patients to see a difference between active drug and placebo. I'm sure IL-23 blockers and interleukin-17 blockers that get you PASI 75 rates of over 90%. You wouldn't need very many people to tell a difference between the drug and the placebo. But we include all of those hundreds of patients because it gives us really good information on the safety of the drug. It would be great to do that for a drug like spesolimab, but you can't because the disease is just so rare. So fortunately, we had enough patients to tell the efficacy really well, but to really understand the safety of the drug, it's going to take a long time, and I think a lot of experience. Imsidolimab is now being tested in phase 3 studies. And through week 24, you see excellent response to the treatment. Half the patients getting a PGA score of clear, almost clear, and nobody getting there in the placebo group. And notice the sample size, it's 15 patients in each group. Again, for these rare diseases, it's a miracle that you could even get that, to get 15 patients be willing to be in the placebo group. And then you can see the maintenance of improvement over time did well with the drug as compared to the placebo. Here's a patient who was treated with spesolimab. I think this is one of the first ones reported. It was a patient with a history of plaque-type psoriasis and psoriatic arthritis who was doing pretty well, but then presented with what was thought to be AJEP, which again may just be a pustular, just a drug-induced form of GPP. The rash developed very quickly after the patient had received steroids for presumed drug eruption. Whether these steroids caused the GPP or not, I don't know. Maybe the patient was headed towards pustular flare anyway. The patient was sent by life flight to the University of Alabama at Birmingham. Patient is febrile and has shaking chills. Why do these patients have chills? Well, they're losing so much heat from their skin. They have to shake their muscles uncontrollably to generate heat to try to keep their body warm. There's pustules all over the body, erythema. The biopsy showed spongiform pustules consistent with pustular psoriasis. The patient was given a single infusion of spesolimab along with some topical steroids, and the rash cleared right up. Complete resolution of pustules in 48 hours, no reported adverse events. This, I think, is indicative of the level of modern medicine at its best, where your researchers discover the gene for interleukin-36. They discover the pathway. They discover the receptor antagonist. They discover that families who have GPP from early age, have the receptor antagonist deficiency, and they're like, the drug company's like, oh, well, I can fix that. And they develop a drug, an antibody, specifically that blocks the interleukin 36 receptor antagonist. And then they put it into people, and it is miraculously effective. That's modern medicine really at its best. So we now have a treatment that's targeted to the disease and its mechanisms of action. Getting that treatment to patients can be tough. You've got to recognize the disease early. The doctor needs to know about the medications and options. I don't think you need any genetic testings, because whether you have an interleukin 36 receptor antagonist deficiency or not, blocking this pathway is effective for treating the flares and is effective for maintenance. So you got to get the right diagnosis, then you got to get the drug approved and make it available. And for a really rare disease like this, with a drug that's not going to be used for much anything else, it may not be stocked locally. And so I think the makers of spesolimab have gone to heroic efforts to make this drug available. So I think within 24 hours, maybe the same day, they would have the drug. They have the drug strategically located so they can get it to your hospital, or your office in short notice. TB testing is recommended when putting people on spesolimab. And so getting that TB test done right away may be valuable, especially if you're getting an insurer to approve it. I believe the first steps when seeing a patient with GPP for getting patients on therapy, one, order the TB test, and two, contact the spesolimab sales representative, because they will help be the conduit for making sure everything gets done that's needed to get that drug available to the patient right away. If you're treating the patient with something else, say an interleukin 17 blocker, those work fast as well. We don't have specific data on their use not controlled trial data for use in GPP, and they're not necessarily approved for GPP, but if you had samples of it on hand, that would be something you could inject into a patient right away and try to give them rapid relief of their disease. So what's happening looking forward? Yes, other things could be done. JAK inhibitors might be very fast acting and could be tried for these pustular diseases. Blocking TYK2 makes sense. From blocking that psoriasis pathway, TYK2, as far as I'm aware, is not involved in the signaling pathway for interleukin 36. But JAK inhibitors have, broad immunosuppression. I feel like they should be effective, but I would worry about more side effects, because if there's an underlying infection driving the disease, then non-specific immune inhibitors like cyclosporin and JAK inhibitors would not be my first choice if I had something more specific. There's an oral interleukin 23 antagonist in development. I think that probably be a great drug for psoriasis. I'm not sure it would be the best choice for a GPP, because GPP is an acute problem, and I'd want something really fast acting. I don't think of IL-23 drugs work pretty fast, but they're not as fast acting as IL-17 drugs. It might be an IL-23 antagonist might be great for long-term maintenance for controlling psoriasis, so to prevent flares happening of GPP. But if somebody were an acute flare, I think I would be looking at faster acting agents like spesolimab, IL-17 inhibitors, cyclosporin would be some of the fastest acting things I think we have. Potentially biomarkers could be used in guiding therapy, but I think getting the result back, yeah, in theory, maybe you could get the result back in hours, but I don't think that's available to us, at least not right now. I want to say something about interdisciplinary care, because these patients are not just seen in dermatology. They're going to be seen by the family doctors. They're going to be seen in the emergency room. So there's going to be a whole care team involved. You want the patient identified early by primary care or the ER. You want them to get the patient to a specialist who will make an accurate diagnosis of GPP. Once the accurate diagnosis is made, whether it's made by primary care or a specialist, getting the patient on therapy is important. patients may be in a lot of pain. I have in the distant past when I had GPP patients, I remember they complained about pain, and I involved the pain medicine specialist who actually gave the patient, I think it was some sort of pain medication pump that I would feel totally uncomfortable giving, but they felt like it was appropriate management. One of the things I think is really important for helping manage the disease acutely is having the office staff get the patients the blankets. It's not good to have the patient with those or losing all of their heat and becoming hypothermic in your office. So once the patient comes in, it's great for the office staff to get them into the exam gown so that you can examine them, but get them covered in ideally pre-warmed blankets to keep them warm while they're waiting for you to do your evaluation. It's important, I think, and valuable to educate patients about their disease, about the triggers, drugs that might cause a flare of AGEP or of their GPP, for example, lithium or beta blockers, making sure they're tracking their symptoms so they can identify their triggers. They may have questions about their diet. I don't know that diet's going to have any effect here, but you could tell them about a Mediterranean diet is anti-inflammatory, have them see a dietitian. One of the things I think is you have like a pre-printed sheet that describes what you want patients to do. I think it's helpful to have options on that sheet and circle the options you want them to do, even if you're circling the same options for every patient every time. Like you might have 3 diets listed, a paleo diet, a Mediterranean diet, standard American diet, a high-fat diet. You're going to circle Mediterranean diet every time. Educate patients about getting care in an appropriate place as early as possible, and address the comorbidities and complications. All right, well, to finish up, GPP is different from plaque psoriasis. It's different in which we see in the skin. It's different immunologically. It's a pathway. While psoriasis is driven by interleukin 23, GPP is driven by interleukin 36 signaling. You want to recognize it early, and now we've got some fabulous treatments that are designed to address the interleukin 36 pathway that we've identified. And we even have, just miraculously, we have controlled clinical trial data for at least one of the treatments, spesolimab, for both the treatment of the acute flare and for the maintenance of the disease. And that brings our discussion to a close for today. I hope you found this activity informative and entertaining and useful to your practice. And I encourage you to access the supplementary program materials. Thank you so very much for participating. I'm Steve Feldman. Thank you so much.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent medical educational grant from Boehringer Ingelheim Pharmaceuticals, Incorporated. To access all materials for this activity, visit peerview.com/BPN860.